All right, it's a pleasure to be here today and visit with you folks. As Corey mentioned, I'm a nurse practitioner. My specialty is psychiatry. I graduated from Washington University back in May of 2012. Before that, I was a registered nurse. Of course, I am a registered nurse anyway. So, next slide. These are some common mental health disorders that I work with. Depression is fairly common. Anxiety, that includes general anxiety disorder, panic attacks, post-traumatic stress disorder. I see quite a bit of that. I don't directly treat dementia disorders, but I treat the depression and anxiety resulting from those disorders. I work with a lot of bipolar or mood disorders. I have patients with schizophrenia. They see a lot of hallucinations. That's a very interesting population of folks. Suicidal thoughts, that's something I always assess for with every patient, every session I sit in with them. I also treat a lot of patients with attention deficit hyperactivity disorder. That's almost half of my practice. There's a lot of people with that issue. Next slide. The reason I put this in here, I think this is significant. As we age, there can be higher risk factors for depression and anxiety. The World Health Organization noted that 15% of the people over the age of 60 have depression. The American Psychological Association puts that at 20.4%, even higher. And to compound that, between the years 2015 and 2050, the population of people over the age of 60 is expected to almost double from 12% to 22%. That indicates a very, I won't be around then in 2050, but that's a big, there'll be a big number of people who will be needing mental health services. And as I mentioned, as we age, we have increasing risk factors for depression and anxiety particularly. These have to do with our physical health. We often develop more limited mobility, chronic pain, frailty, and the need for some forms of assisted care. Many of my patients do come from assisted care facilities. Additionally, we experience events such as bereavement. As we age, more of our family members and close friends pass away. There's a drop in socioeconomic status when we retire. Our incomes become more limited, and often we are disabled. These factors often lead to isolation, loss of dependence, loneliness. These compound these psychological stressors in our lives. Next slide. Okay. Some of the potential causes are genetics. Genetics do play a significant role in mental health disorders. It's estimated that in depression, there's a 50 to 70% genetic component in there. But genes by themselves are not sufficient enough to cause depression. It takes environmental factors, the stressors in our lives. These stressors I mentioned earlier, like changes in health, these can affect us as well, financial concerns. And this is kind of a note I wanted to make here. I used to think that folks with mental health disorders, like they thought themselves into it, therefore they can think themselves out of it. That's just not the case. People with depression and anxiety would have no desire to have those disorders if they had a choice. Okay? These deal a lot, like say, with genetics and the situations that they are going through in their lives that really drive these stressors. These dysfunctioning in the neurons in the brain and what we call neurotransmitters. Chemicals are important in transferring messages from one neuron to the next neuron in the brain. Next slide. Okay. Basically what I mentioned here before, there's that genetic predispositions that affect us a lot, and these factors that we encounter as we age. Well, anybody can have these situations that drive their stress factors too. Next slide. What do we got there? Okay. One other thing I do want to mention before I talk about this slide, that a lot of people develop adaptive behaviors to deal with their stressors, coping skills, but a lot of people with genetic predispositions just when you get a lot of these genetic risk factors and multiple stressors, it just overwhelms them. And they don't react the same as everybody else. It brings them down. They have greater difficulties. They get that depression, anxiety issues. First mental health disorder I want to talk about is major depressive disorder. The diagnostic criteria for major depressive disorder is this general depressed mood, this empty feeling that a person has all the time, a diminished interest or loss of pleasure in the things they used to enjoy, the activities used to be involved in. We often see a significant loss in weight, but generally it's a gain in weight. We see a decrease or increase of appetite. There's often insomnia and sometimes hypersomnia. I saw a patient this morning that told me that she will take a nap at 3 o'clock in the afternoon until 6 o'clock, get up and go back to bed at 9 o'clock and sleep to 8 o'clock the next morning. That's a lot of sleeping. She has no motivation to get up and do anything. We also see a lot of what we call psychomotor agitation or psychomotor retardation. Basically all that is moving or talking more slowly than normal or feeling restless and having trouble sitting still. For those with the psychomotor retardation, they explained to me it's like trying to crawl through mud all day long and can't hardly move. There's a general feeling of fatigue or loss of energy. Feelings of worthlessness, excessive inappropriate guilt, and a general attitude of pessimism all day long. Diminished ability to think or concentrate. These folks are generally very indecisive about most anything. We see recurrent thoughts of death, not just fear of dying, but these recurrent thoughts I think about a lot, recurrent suicidal thoughts without any specific plan. We often have patients that have had past suicidal attempts or a specific plan for committing suicide. And the thing about these criteria, these symptoms, they must exist most of the day, nearly every day, to be distinguished for major depressive disorder. So it's very, very difficult lives for those folks. Next slide. Okay. So notes here that patients frequently go see the primary care provider with these symptoms, these aches and pains, these cramps, digestive problems, and there's no clear indication of why they're having these problems. They treat them for a while, nothing clears up. They start thinking, well, maybe there's a mental component here, and then that's usually when I end up seeing. My patients are referred to me from other practitioners. Depression can occur in midlife or later life with other serious medical illnesses, things like diabetes, cancer, heart disease, and Parkinson's disease as well. Next slide. Now there's some medical conditions that have symptoms of depression like diabetes, decreased folate levels. Folate's one of the B vitamins. Vitamin B12. I remember back when I was going to school, one of the students was telling about a patient that she saw, a gentleman that came in, was about 47 years old, no family history of depression, but he had this severe depressive symptoms. They did some labs on him and just found that his vitamin B12 levels were really low. They gave him a shot. He was doing fine after that. Okay. Hypothyroidism, symptoms show up as fatigue, weakness, depression, memory loss, so we work on those kind of things. So we often do a lot of labs when people first come in if we can't figure out what's going on here. If there's some indications there may be an issue other than genetic caused or situationally caused depression. Okay, people can be depressed but not necessarily have full-blown major depressive disorder. They have this general feeling of just lowness, sadness, this pervasive depressive disorder we call dysthymia. We'll see premenstrual dysphoric disorders in women sometimes. Some medications and substances that people use can cause depression. And then, some of these other ones, just medical conditions, and we have a little classification we call unspecified depressive disorder. They have depression, but it's not really, doesn't fit in with everything, so we put in unspecified a lot. But we still treat it about the same. Next slide. Okay, I recommend to my patients that they do counseling, psychotherapy. I find that psychotherapies really work well in helping people learn skills on how to cope with things. Along with the medications, they do better. You see less issues with relapse those kind of things. The common therapy they use is called cognitive behavioral therapy. As you see on that little picture there, people have events and situations. Because of that, we have these consequences, the emotions, the sadness, the irritability, the anger, whatever it may be. We see behavioral responses like isolation. We also see physical responses, tension, okay? For example, studies show it's not the situation of the event that causes these consequences. Otherwise, we'd all react the same, and we don't. So the difference is how a person thinks about it. This is the worst thing that ever happened to me. I can't stand this. My life is ruined. Things like that, magnify the symptoms, and people develop more of these consequences. So they teach people how to look at their thoughts, balance them out with the overall picture of life. What supports my thoughts? What doesn't support my thought? They rewrite their thoughts and are able to reduce a lot of these consequences. Next slide. Here we go. Mindfulness meditation, we're seeing more of that in the psychotherapy and counseling programs. So you note on here, they're primarily awareness techniques. They're very calming for people. It's a non-judgmental way to look at the stressors in their lives. Meditation is centered more on focus on the breathing, excluding all other thoughts. Meditation, I went to a class one time when they taught that, and we sat there and we focused on just doing this, and see how long you can just sit there and focus on this, the feeling you have between the two fingers before your mind drifts to other thoughts. It's this process of learning how to meditate without other thoughts coming in. Mindfulness is more of a state of awareness of internal and external stimuli in a non-judgmental way. Next slide. Okay, exercise. I think exercise is an extremely important part of therapy for depression. In graduate school, I did my graduate project on exercise as therapy for depression. And exercise, a 30-minute exercise, moderate intensity for 4 or 5 times a week, is as effective for depression as psychotherapy and psychotropic medications. Now, when you get into more of the moderately high and severe depression, yeah, you're definitely going to need medications. But the combination of medications, psychotherapy, and exercise is a very good combination in treating a lot of our mental health disorders. Okay, next slide. Now, speaking of medications, of course, we have the antidepressants. We have the SSRIs, which are selective serotonin reuptake inhibitors. That's a big, loud, long title, isn't it? And then we have the serotonin norepinephrine reuptake inhibitors. All that really means is that when neurons send a message from one neuron to another neuron, neurons don't actually attach to each other. There's a gap between them. So it sends an impulse down here, and it doesn't jump across like a spark plug, but it releases a chemical. We call these chemicals neurotransmitters. They're neurotransmitters are serotonin, norepinephrine, dopamine. Those are some of them. But they're supposed to drift across from a presynaptic neuron over to a postsynaptic neuron and hit a receptor and send the message on. Well, in theory, there isn't as much neurotransmitter in that synapse as there should be. And to make the problem even worse, these presynaptic neurons have reuptake pumps that just suck that right back in before it gets across the synapse to hit a neuron over here. So these SSRIs and SNRIs, they block those reuptake pumps. So you can get more neurotransmitter going across, hitting receptors over here, and you get the impulses you need to have in your brain to feel good. And that's basically how they work. In fact, most of our medications are geared towards addressing neurotransmitter issues. Yes, she asked about whether there's side effects to these medications. It's a good question. There's a slide coming up, and so we'll talk about those in a minute. There's side effects to all the medications, okay? So other antidepressants are the tricyclic antidepressants. They're older line antidepressants. We don't use them as much. They use them a little bit in family practice, like amitriptyline, to treat neuropathic pain, nerve pain. And some practitioners will prescribe amitriptyline, for example, to help people sleep. I use one of the tricyclics called doxepin. I occasionally use that for depression or anxiety. Monoamine oxidase inhibitors, I don't use those at all. There's a high risk of what we call hypertensive crisis. Some of the foods that we eat have a chemical in called tyramine, which can increase the amount of norepinephrine, which shrinks or constricts our blood vessels, causing this very high level of hypertension. So I avoid those things because it's hard for people to adjust their diet so much that when they're on those meds, it becomes very difficult to use them. They are effective, though. They are effective. Other meds I use Wellbutrin quite a bit. I occasionally use Remeron. Remeron has a lot of problems with weight gain, for example, and increased appetite. But I have some elderly patients that don't eat well. They're losing weight because of diminished appetite, and they have depression. So I will prescribe Remeron in cases like that. It picks up their appetite a little bit, they stop losing weight, and it treats their depression. We actually use antipsychotics to treat depression. We do not use we use antipsychotics, of course, for psychosis, hallucinations, but they're very versatile medications for treating resistant treatment depression and mood disorders, as well as for psychosis. Occasionally we use stimulants. When people are really, really depressed, they just can't come out of it, they can't think clearly, we will put a stimulant in there that kind of brightens them up. And occasionally we'll use mood stabilizers, can't speak today, like lithium or lamotrigine. Prozac is a selective serotonin reuptake inhibitor. I use Prozac occasionally, but there's also all these other ones listed here. Prozac and Zoloft are two of the more activating of the antidepressants in this family. I use them if a patient is just this hypersomnolence and sleeping all the time. I might go to something more like Prozac or Zoloft. It brightens them up. It can cause a reduction in all the sleeping. Medications like Celex and Lexapro, we call those kind of neutral. They don't cause insomnia. They don't cause sedation very often, though I do have some patients that do have sedation or activation with those two medications. Paxil and Luvox are more sedating. We use Luvox more for obsessive compulsive disorder. And then the Vibrid and the Trintellix are newer ones. Trintellix is a really great antidepressant, but it's new and it's tough to get people on it. Get insurance companies to accept that. You have to fill on at least 2 other medications before you can go there. Next slide. Okay, as I mentioned before how the medications work. The other thing I want to mention on here is that they do work slowly. Antidepressants like SSRIs take 4 to 6 weeks to get full effect. We do titrate up as we go along over that period of time, and it's not that you don't feel anything for 4 to 6 weeks. You do start feeling it's very gradual, but it takes 4 to 6 weeks before you know whether it's going to really work for you or not. The other thing I see when I treat patients is that I'll prescribe, say, something like Celexa. Sometimes I'll find with any of those medications, nothing works. That first med, just nothing. Okay, 4 to 6 weeks, they don't feel any different. Then I have to switch to a different med. But I find that the majority of my patients get some benefits, a partial response. And so when I get a partial response, I have to add another medication in. And then with the rest of the patients, I get about 15%. One medication does it all, and that's wonderful. I wish it was like that all the time, but it's not. Okay, we often use several medications to take care of things. And the question that the man had back there, he mentioned trazodone. Trazodone is an antidepressant, at least that was developed for that, but it takes super high doses to get the antidepressant effect. It's used more often for insomnia. Okay, I prescribe it frequently for insomnia. It has a half-life, that meaning the time it hits the bloodstream, half it's out in a certain period of time, but it has a half-life of about 8 hours, so it knocks people out pretty good. I used to work with injured workers, patients covered by labor and industries, and a lot of them couldn't sleep well because of the pain, the chronic pain they had from their injuries, so we'd prescribe them trazodone to help them sleep. And the pain would wake them up frequently, but the trazodone was strong enough to put them back to sleep after a few minutes, 15, 20 minutes. They could get a nice sleep better that way. And so that's where we use trazodone a lot more now. Let's see where I'm at. Okay. Common side effects you see on there. You asked about side effects over there. Nausea, headaches, diarrhea, constipation. dry mouth. Most of these side effects will go away within a couple of weeks, except dry mouth seems to hang around forever. So you chew gum, drink a little water, keep that dryness down. And the thing too about antidepressants, patients will start on them, they get feeling good, they'll stop taking them. And the challenge with that is that the more often they take them and then you get another episode of depression coming back, the more episodes you have of depression, the harder it becomes to treat the depression. The more medications you have to use, the higher doses you have to use. Okay, next slide. Okay, the SNRIs, the effects are Cymbalta, Pristiq. These are good medications, as I mentioned before. They're good for depression and anxiety, but they're also good for nerve pains, neuropathic pains, diabetic neuropathies. When I worked with injured workers, the other practitioners would prescribe a lot of Cymbalta for people with, say, back injuries, low back injuries, pinched nerves, things like that. It seemed to help them quite a bit. Okay? And it took care of the depression as well. Next slide. Okay, tricyclic antidepressants, as I mentioned earlier, don't use that very often. We do use medications like clomipramine for obsessive-compulsive disorder. Side effects that you see are very similar. One side effect we take advantage of is urinary retention. We will use some of these medications for children with bedwetting problems. It slows down that bladder and can be helpful there. The other issues we have with the tricyclics on their side effects, they have more sexual dysfunction side effects, cardiac effects such as tachycardia, rapid heartbeat, and a prolonged QT interval. And you see the pictures, the heart wave like that. What it does, it stretches that out just a little bit longer, 2-3 milliseconds. That doesn't sound like very much, but it can be an issue in cardiac problems. Okay. But basically the idea when we use any of the antidepressants is to increase the availability of neurotransmitters in that synapse I talked about earlier. Okay, symptoms that we see, as you notice up there, okay, well, we have a lot of issues with worrying, feeling really keyed up, can't sleep because the mind won't shut down at night, a lot of irritability and muscle tension. We see that a lot with the anxiety disorders. Next slide. There we go. Specific phobias, I don't really deal with those particularly, but I do deal with social anxiety disorder, panic disorder. I have a lot of patients with panic disorder, some with post-traumatic stress disorder because of the traumas they've had experienced in the past, agoraphobia, and we do see a lot of anxiety disorders from substances or medication uses. Let's go to the next slide and I'll talk a little bit about panic disorder. There we go. Okay, as it says up there, it's an abrupt surge of intense fear, intense discomfort that reaches a peak within minutes. It's very fast. These sudden unexpected periods of intense fears are often recurrent. I have patients that maybe only have 1 or 2 over a 2 or 3 year period, but I have patients who will have 2 or 3 panic attacks every day. They can last from a few minutes to several hours. It's just causes a lot of dysfunction for people. These symptoms, these palpitations, this pounding heart, accelerated heart rate are one of the symptoms we often see. A lot of sweating, trembling, shaking, sensations of shortness of breath, or they just like they're choking or smothering, chest pain or just discomfort in the chest. A lot of nausea, abdominal stress. Some of the patients get so tensed out on this that they literally vomit. A lot of dizziness, unsteadiness, lightheadedness, faintness. You can have chills or the opposite, heat sensations, numbness or tingling sensations. Usually they feel that out here in the arms or sometimes around the mouth. There's feelings that we call unreality, a derealization, or a feeling of being detached from oneself. A lot of people feel like they're just losing control or going crazy or they're dying. A lot of people have been to the hospital thinking that they are dying and find out, thankfully, that they aren't. And they put them on a little Ativan, they calm down, they do pretty good. And they recognize next time they have a panic attack what it is. On the treatment of anxiety disorders, first line are the benzodiazepines, the list that you see up there. I don't prescribe very much Xanax. Xanax has some dependency issues more than the others. They all have dependency issues, but Xanax is particularly more addictive. It works really well though, but it has this very short half-life, so you have to use a lot more of it. The benefits, as it mentions up there, is they work rapidly, okay? We also use, we'll see this in the next slide, to treat anxiety. We use antidepressants, the SSRIs and the SNRIs, but they work very slowly, as I mentioned before, 4 to 6 weeks. So we start people on a benzodiazepine to calm them down, to get them through there, and we'll keep them on there for a while till the antidepressants get working well, then we taper them off of the benzodiazepines because of the issues with dependency. Other concerns we have with benzodiazepines is that they do reduce the respiratory response, so we have to be particularly cautious when a person's on any kind of a pain medication, which also reduce the respiratory response, or if a patient has issues with alcohol abuse. So those do become significant issues. Also, confusion and sedation can increase the risk for falls when a person's on benzodiazepines. So, next slide. We're there. Okay, SSRIs, SNRIs, tricyclic antidepressants are also used for depression. I use doxepin sometimes for anxiety. Buspar. Buspar is useful for mild anxiety. A person with high anxiety or panic attacks, Buspar is not going to even touch them. Propranolol and clonidine, some of you may recognize those. Those are for hypertension, but we do use them because they control the rapid heart rate, the shaking, the trembling, and blushing. Clonidine I use infrequently, but sometimes I have some patients, students that do have to do presentations, or people because of their jobs have to do presentations. That works really nice, slowing down that heart rate, the sweating, the shaking, the blushing issues, and they can do the presentations without that high tension anxiety feeling. So, and occasionally we do go into gabapentin, which is actually for seizures and neuralgic pain, but it modulates a chemical called glutamate, another neurotransmitter that's an excitatory chemical, and tones that down and can reduce anxiety as well. Okay, again, the psychotherapy, cognitive behavioral therapy is very useful in helping people understand their anxiety. As I mentioned earlier, there's a lot of, how should I put this, learned responses in anxiety as well. And so cognitive behavioral therapy can help with that part of it too. Oftentimes we use exposure therapies for people like with PTSD, that have a lot of vivid memories of past traumas. And then relaxation breathing. I teach most of my patients relaxation breathing. They used to teach us in a 4 count. You breathe in for the count of 4, you hold it for the count of 4, you exhale the count of 4, you hold the count of 4 and start over. It never worked for me. I got too nervous holding it for the count of 4 every time. So for me, I breathe in basically the count of 4. I pause for maybe 2 seconds. And then I breathe out for count of 4 or 5, and then I pause a couple seconds and I start again. That's very relaxing for me. I've been in it the whole time. I've been waiting to do this presentation today because this is very nervous for me to do this. But when we exhale, we trigger the parasympathetic nervous system, which is our relaxation response. You've all had those experiences whenever you were tense, and when it was all over, you went, glad that's over. Okay, that's kicking in your relaxation response, and that's what you do with this relaxation breathing technique. So it's something, if you practice it and get used to using it, when you get in a tense situation, you automatically reach out and start doing it. You don't have to think about it anymore, okay? All right, next slide. Neurocognitive disorders, those are dementia. As I mentioned earlier, I don't directly treat them except for the depression, anxiety that often these folks have. But it's a progressive impairment of cognitive function. There's this impairment in intellect manifested with difficulty in memory, attention, thinking, and comprehension. We see impairment in social and occupational function, and these decline kind of runs, you kind of decline, flatten out for a while, decline, flatten out, go down. My mother had Alzheimer's, and it was difficult watching her go through this decline in her life. The most common type is Alzheimer's. We also have ones we call Pick's disease, Lewy body disease, and vascular dementia. Not much people can do about those except for vascular dementia because that's more related to hypertension. And so if we keep our cardiac condition in good shape, we have less problems with that. Next slide. Delirium, sometimes people have these deliriums. It's like dementia, but it's really quite different. It's very acute, sudden onset, whereas dementia is a very gradual progression. And with delirium, people kind of fluctuate in and out of awareness. Okay, there are different causes for that. Central nervous system diseases like epilepsy, cardiac failure, intoxication or withdrawal from toxic agents. You'll see this, people withdrawing from alcohol or other drugs. Fevers, pain medication, electrolyte imbalances, infection, blood loss, all these things can contribute to delirium. I remember years ago when I came out of the Army, I was working in hospitals in orderly, and I heard this man screaming. I go into the room back when they had the wards, 4 or 5 beds in a room type, those bigger rooms. He was standing on top of his bed yelling and screaming. He was on a pain med, an older kind we used to use years ago, screaming about this river of fiery serpents circling his bed. And so that's what some of those old pain meds used to do. Okay. But really, the basic difference then, next slide. Okay, is a suddenness of onset. That's what we look for. If it came on real quick, it's probably delirium, and you start looking at what's going on. You may have to change medications. Let's see. Okay, we're talking about this suddenness, this fluctuation presentation deals more with delirium, where dementia is very slow. Let's go on to the next slide. Again, treatment, the psychosocial therapies teach people how to function with what alertness they still have, help them deal with things better. Medications that are commonly used are Aricept, Exelon, and Namenda. You usually see them start with Aricept and Exelon, and then they go to Namenda, add that in later. Okay. Next slide. All right, bipolar, we used to call that manic depressive disorder because there definitely is a manic episode in there. This is a brain disorder that causes these very unusual shifts in mood, energy, activity levels, and the ability to carry out daily activities. It can be very disabling for some people. Bipolar 1, I treat people with bipolar 1, bipolar 2. You can get it from substances. I see people with use meth have a lot of manic episodes as well. We'll see that if we get too aggressive with the SSRIs or the SNRIs for depression, we get too much serotonin. Too much serotonin can actually push a person into a manic episode. I do use the antidepressants with people with depression, and that also have the bipolar, because depression is part of the bipolar. But I have to manage it very carefully. So we still use that. There's usually a major depressive disorder, but there does not have to be a major depressive disorder in bipolar 1. But there has to be a manic episode. In a manic episode, you have this elevated, expansive mood, and sometimes, though, it's an irritable mood. I saw one gentleman, he was a physician. He used to go to third world countries and treat patients there, and he was having a manic episode. He was writing all over the walls of his hotel room he was in before they brought him in, but he was going to raise this army, these grandiose ideas of raising an army, overthrowing the government in that third world country and setting up a democratic government so that these people could get better care. Very grandiose. But after a while, he came down, he got this very irritable towards the end of that too, though. So we see this grandiose, expansive change. People who become very goal-oriented, high activity levels. There's usually a decreased need for sleep. Sometimes people get along fine with just 3 hours of sleep is all. I remember when I was training, following a psychiatrist, this young lady came in one time. She was starting the 3rd week of a manic episode. She had been working 3 8-hour jobs in a row every day for 2 weeks. Unbelievable. she was getting on the very irritable side, about to drop off the end there. So people have what we call pressured speech. They're very talkative, and they talk so fast people can't understand them, and that's because of this flight of ideas. The ideas are coming in, these racing thoughts are coming in the brain so fast they can't even keep up with them. They're just thoughts are tumbling over each other. And so they're trying to talk to people about these thoughts in their mind. Well, one thought comes in before another thought's done, and so their one comment isn't finished before they start another comment, and they're jabbering so fast, you know, oh, what are you on, you know? Think they're on speed or something, but they're not. They're just in a manic episode. They're very distracted, though. They'll start lots of projects. They have this intense goal-directed activities to start all these projects, but because they're so distracted, they don't finish them. Some do, but some will go from one project to the next, to the next, to the next. I did have one patient one time that she was on a manic episode for about a week, and she painted her living room 4 times in that week. So that was kind of an expensive manic episode. We're painting our living room right now. It's kind of, wouldn't want to paint it 4 times. Okay. There's also excessive involvement in activities that have a high potential for painful consequences, we call it. This exaggerated, unrestrained buying sprees, that's pretty common. A lot of sexual indiscretions or foolish business investments. High physical risk type behaviors. And again, there is... I guess I better jump one more slide. I'm getting down here. Oh yeah, okay, there's a genetic component in there. I frequently find someone who has bipolar, somebody else in his family has bipolar. Okay, very, very common. 10-fold risk of that. Again, I also see a lot of people with bipolar will also have psychotic experiences from time to time. That's not unusual as well. So we have to treat both, and there's ways we do that. And let me talk a little bit about bipolar 2, because that was asked. So next slide. Okay, it's very similar. The symptoms are the same as we see in bipolar 1, the manic stuff, except they're not as severe. Okay, they do not interfere with the person's ability to socially interact with people or go to work, at least not as bad. A lot of times bipolar 1, people have to be inpatient. With bipolar 2, they're not. And generally the hypomanic episodes do not last as long. Okay. With bipolar 2, though, there has to be a major depressive episode to be diagnosed bipolar 2. Okay. So let's go on. Okay, treatment. Okay, mood stabilizers, lithium. Lithium works well, but a lot of people cannot tolerate it. There's weight gain, other issues with lithium. We have to frequently do blood draws to determine the level of lithium in the blood. It has what we call a narrow therapeutic treatment range. Below a certain level, it's not as effective. Above a certain level, it's toxic. Okay. And long-term effect can be adverse on the kidneys and on the thyroid. Okay. Anticonvulsants. That's your Lamictal, Depakote, Tegretol, Trileptal. These are anti-seizure medications. I use Lamictal a lot for bipolar depression and Depakote for bipolar mania. Okay. Next slide. We also use antipsychotics. So again, it's particularly I mentioned where someone may be manic and having psychotic events, it's really nice to have antipsychotics in there as well. I like to use antipsychotics because they reduce the need for as much lithium if I'm doing lithium as well. And then we reduce the risk of toxic effect on the thyroid and the kidneys. Those are the general ones that we use. There's more than that. These are what we call second generation. The old first generation, the ones that came out years ago, Thorazine, Haldol. We still use them. When I was in the Army or in Vietnam, we would use Thorazine. We get these guys that would get all liquored up, and then they're out in the middle of the compound with a weapon threatening to shoot anybody they could see. So some of us would get over behind some sandbags and yell at them and stuff, distract them, and the other guys come up behind them, pull them down, then we'd haul them up to dispensary, shoot Thorazine, mainline it right in, put them out. Next day they were very humble young men. But yeah, I used Thorazine back then. So, and it's these medications, Risperdal, Zyprexa, Seroquel, Geodon are sedating. Abilify is not. The challenges we get with Abilify is it increases blood sugars in some people that are diabetic or borderline diabetic. And that is the issue really with some of the rest of them too. We can get what we call metabolic syndrome, which is abdominal obesity, high triglyceride levels, low HDL levels, high blood sugar levels, hypertension. So we have to watch that when we use those meds. Therefore, we're doing labs all the time and monitoring the effect on a person. Okay, let's go to the next slide. Antidepressants. I do use antidepressants for depression with bipolar. I mentioned that earlier, but I have to watch the level so I don't increase the manic episodes or the cycling of those episodes. Okay, and occasionally I will use Wellbutrin or Remeron. So next slide. Okay, again, cognitive behavioral therapy is useful in treating people with bipolar. Family-focused therapy, because people with bipolar, their illness can really affect the family. Just put this one thought in here. I find with people with bipolar 1 patients really enjoy the manic episode. They feel like they get more done, they feel alive, but it's heck on the family. It's really difficult for the family. That last bullet there, it's not unusual to see patients with mood disorders that also have ADHD and anxiety. A lot of my ADHD patients also have mood disorders, just very common. The decision is, what do we treat first? Which is the most predominant and disabling illness that's going on. So, okay, next slide. As I mentioned earlier, when I assess patients, I assess them every time I see them for suicidal thoughts. The suicidal risk is higher in individuals with mental health disorders. It is often reported as high as 15%. That's very high. The World Health Organization reported in the early 2000s that the suicides are as high as 750,000 individuals annually worldwide. And a vast majority of those people have mental health disorders. Okay. Next slide. Some of the risk factors we look for suicide is adolescence. There's a high risk factor in adolescence for suicide. It's one of the top causes of death in children or adolescents, and also late life. Delusions can affect people's focus and understanding of life and the loss of control. Family history of suicide is a predominant factor. Hopelessness, past suicide attempts and how lethal were those attempts. Male gender, living alone, physical illnesses or impairment, recent loss, severe psychiatric disease, unemployment, and drug use. I've had a number of patients tell me lately they've had a sibling who was a drug user, very heavy drug user, and took their life later on because of the drugs and the hopelessness that they derive from the effects of drug use. Okay, let's go on to the next slide. Okay. I look for their thought processes. Are they talking about wanting to die, and how frequently are they talking about death? This empty or hopeless feeling, no solutions in life. Feelings of guilt or shame are important. Unbearable pain, and pain can be both emotional as well as physical pain. And whether being a burden to others, we talked about that earlier. And so those are things we look for and ask about. And also, next slide. There we go. Intent. How lethal are they? Do they have a plan? And if they have a plan, how lethal is their plan? Frequently, my patients tell me that they wish they could die, but they have no plans. They're just tired of what they're going through. But I do get patients, particularly when I was working with injured workers, that sometimes would have very extreme intents and lethality with their intents. In those cases, then we call 911 and start working from there. But women, females often overdose, and males frequently use guns. Far more lethal with a gun. We observe for changes like eating, sleeping habits. Those are indicator. Extreme swings in moods, especially from very sad, also into a very calm, happy mood. Giving away important possessions, saying goodbye to friends and family, putting affairs in order, making a will. Those are red flags right there. That means they've made up their mind, their intent is very high. Okay, next slide. Okay, suicide prevention, or at least trying. We want to keep people safe that have suicidal thoughts. We ask them, are you thinking about killing yourself or taking your life? This question does not increase suicide or suicidal thoughts. When I first started practicing, that was very hard for me. I was worried about that. But it's the best thing you can do. Is just ask them outright. Okay? You keep them safe by reducing access to highly lethal items like guns, particularly, poisons, or places. Okay? Be there. Be a support for them. Listen to them. Let them talk out their suicidal thoughts. Studies indicate, as I mentioned before, acknowledging and talking about suicide may reduce rather than increase suicidal thoughts. It's very therapeutic for people to talk about what's on their mind. We call that catharsis. Get it out. Listen to it as you tell the other person. It calms people down sometimes, to particularly know that somebody else is listening to them. Help them connect. Have local suicide hotlines available or National Suicide Prevention Lifeline. Help them make those connections with a trusted individual. And stay connected. Suicides decrease when someone follows up with an at-risk individual. Excuse me. Next slide.
Where do you find that phone number? It's not a phone book, is it?
I don't know. I just have it. A lot of times I will give patients materials and stuff if we see things like that. You can also, there is a crisis line locally here in the area, Benton Franklin County crisis line. The fastest, easiest way is to call 911 or go straight to the hospital. That works best. Okay. Again, cognitive behavioral therapy, let people work through what's going on. Like I say, cognitive behavioral therapy, community social service may be helpful in helping people work through some of the things that are going on that they feel like they cannot control. That can be useful. Medications, of course. Clozapine is an antipsychotic. We don't use it much. It's kind of a last resort for psychosis, but it's very good at calming people down that are feeling suicidal, as well as lithium. Lithium is also very useful. Okay, next slide. Thoughts. Okay, these are kind of some thoughts I had to end up on here. Talking again about exercise. These are things that you can do to reduce the effects of mental health disorders or reduce the risk of developing a mental disorder. And also many of these strategies also are good for us physically. So exercise, I mentioned that earlier. A recent article I read in a Medline Plus entitled "Even a Little Exercise May Stave Off Dementia." It said that couch potatoes have a higher risk of developing dementia in old age, a 50% higher risk. The U.S. Centers for Disease Control and Prevention suggests a brisk walk, bicycling, ballroom dancing, or gardening. Those are some of the things that you can do. Seniors who exercise regularly are better able to withstand the effects of aging on the brain. There's a tendency for increased neural connections due to increased blood flow through the brain. There's also an increase in that BDNF. I mentioned that neuroprotective chemical in there. Another thing I read here recently came through on a Medscape article that said that this is kind of a serendipity, that exercise can help reduce wrinkles. I don't know. It said something about increasing the collagen under the layers of the skin. So I thought, well, that's interesting. I better get exercising more. So, all right. Then good nutrition. Just some simple thoughts on that. Just kind of watch those carbohydrates, particularly the simple carbohydrates, the sugary foods, starchy foods like white potatoes, white bread, rice, you know, those kind of things. Watch those. Stick to the complex carbohydrates. Protein-based meals with complex carbohydrates are what we need to be at. There's always a question, do we do 3 meals a day or do we do 6? Okay. Some studies are showing 6 small meals, protein-based complex carbohydrates are better because you don't get those drops in blood sugar and you stay at pretty level energy levels through the day and you maintain weight better. Psychotropic medications may be long life in order to function well though. So that's kind of the end. You hit that last slide, there you go.